All right, shall we get started? All right, welcome everyone. Welcome to the FPMRS Fellow Webinar Series. This is a joint effort between AUGS, SUFU, and SGS, and we are really grateful for their support. I'm Jessica Rube. I'm a senior fellow at the Cleveland Clinic, and I'll be moderating today's webinar. Today's webinar, we'll be discussing urinary tract infections. We have a great panel for you. Dr. Nihira is going to cover, he's from the University of California. He's going to cover some of the board relevant points of, that we need to cover as fellows. Then we have Dr. Anger and Dr. Ackerman from Cedars-Sinai. They'll be going over the recent recurrent UTI guidelines, as well as some case presentations for us to have a discussion. In the last 15 minutes, we're going to try to open it up to questions for panelists and try to cover that as well. In case anyone is watching for the first time, just some housekeeping items. This webinar is live streamed and recorded. All participants will be on mute, but please, if you have any questions, use the Q&A feature of the Zoom webinar, and I'll be monitoring that to bring up questions to the panelists. The chat feature is for technical issues, and the AUG staff will be monitoring that and can assist if you have any issues. And at the end of the webinar, you'll be prompted to complete a brief survey and provide feedback about the session. I also want to let everybody know that next Tuesday, we have the continuation of our webinar with painful bladder syndrome with Dr. Goldman, and you can register at the AUGS website. All right.
Good morning. Can everyone hear me? Good morning, yes. Everyone. I'm Mikio Nihira, and excellent. I'm Mikio Nihira. So I'll tell you that my experience doing chronic cystitis on a national level was basically, I was the person who got tagged for this topic at the review course. And initially I was kind of sad because it certainly isn't the most sexy topic. Having said that, as soon as I started digging into it, it was obvious, and it caused me self-reflection that it's about 15% of my practice is trying to manage women who have or have been accused of having chronic bladder infection. And I say accused of having because it overlaps so much with other things that we treat, like painful bladder syndrome and overactive bladder. So it is a ubiquitous problem. And it's a problem that really brings a lot of suffering to women. So unfortunately, I've had 3 patients in the emergency room who scalded themselves in the hopes of sterilizing their genitalia. And it is just a major challenge. Having said that, you would think that a condition like cystitis, where the primary diagnosis should be made by their symptoms, right, with dysuria. And you think that, wow, doctors should be awesome at treating this. And unfortunately, that's not the case. So we have continued need for education and re-education of doctors over and over again to try to optimize the situation. So what you see in front of you is what the boards have agreed upon. And I want to bring this to all fellows' attention to make sure that you guys know what is going to be expected of you for standardized testing. Having said that, we have great opportunities for education, and Dr. Anger has recently presented on a publication. Colleen, can we go to the next slide? So this is one of what I counted of 8 recent publications. This is the most recent of them, where groups have gone to try to create a algorithmic approach to treating this very simple but complicated issue. And with that, I'm going to hand it over to Dr. Anger.
Okay, let's see if we get this to work. Yay, okay. Well, good morning, everybody. This is a nice opportunity, which I think is going to be short-lived because it looks like a lot of people are actually going back into surgery again, which is a blessing. But I must say, we've all learned so much with Zoom meetings and bringing additional people into our regular hospital-based meetings. So I thank you for being here, and hopefully we can continue this FPMRS Zoom series even after we, God willing, we're back into our day-to-day routine. So the index patient I want to just make sure that you guys do see the slide. It's working. Just maybe wave. An otherwise healthy adult woman with uncomplicated culture-proven recurrent urinary tract infection associated with acute onset of symptoms. So this means that her prior episodes were in fact culture-proven to differentiate her symptoms from other things that cause dysuria. Acute bacterial cystitis is a culture-proven infection with acute onset of symptoms. The most diagnostic symptom is dysuria associated with other symptoms. A complicated UTI includes someone who might have a predisposition or anatomic abnormality, immunocompromised state, for example. That's not the patient here. Uncomplicated UTI is an infection in a patient with normal anatomy and no factors that would make her susceptible to develop UTI. Recurrent UTI is 2 culture-proven episodes in 6 months or 3 in 12 months. Asymptomatic bacteriuria is the presence of bacteria in the urine that do not cause symptoms, and that is different from an acute UTI. Dysuria is essential to the diagnosis of UTI. So when they have frequency and urgency, suprapubic pain, we have a larger differential and really need to make sure that we don't have something else. So dysuria is more than 90% accurate in diagnosis of UTI. And whenever a patient has symptoms, this should go, we want to obtain cultures in these women at all times. So we conducted a systematic review, and then we had a UTI panel who analyzed the data available. We searched several sites and then supplemented the reviewing articles with lists of from the reference list of those articles. And this data search took place until September 2018. There were 6,000 articles, 214 of which we used, and then 65 studies and 67 publications met inclusion criteria, and there were additional 10 from reference lists. So I'm just going to briefly highlight the 16 guidelines. The first is that a clinician should obtain a complete history and perform a physical exam. This seems pretty obvious, but we see a tremendous amount of UTIs being treated over the phone, and we have to make sure that we are diagnosing women correctly. Number 2, a clinician must document positive cultures associated with prior symptomatic episodes. What that means is that to diagnose recurrent UTI, we want to have prior cultures. We don't want to just simply know that that they had symptoms that got better, maybe not. We want to ideally get their prior culture records. Clinicians should obtain repeat studies when initial specimen is suspect for contamination. This is a big problem. We have women who, anytime they pee in a cup, vaginal bacteria and vaginal cells go into that cup. So when we see group B strep, it's really hard to tell patients that we don't need to treat it. And many with the gynecology OBGYN background is we don't need to treat strep unless women are delivering a baby. When there is high index of suspension, we have a low threshold to obtain a catheterized sample, which are so much more accurate. Cystoscopy and upper tract imaging should not be routinely performed in the index patient. This is sometimes tricky as patients get referred to us and they are asking for a cystoscopy, but most of the time it's not necessary. Clinicians should obtain a urinalysis, culture, and sensitivity with each symptomatic episode prior to initiating treatment. this is what the UTI guidelines really changed. We really want to stop the practice of treating over the phone, treating empirically. And when we get a culture, we're able to, we know what we're treating and we have a better handle on development of resistance patterns. Clinicians may offer self-start therapy, which is patient-initiated treatment, to select patients with acute episodes while waiting for cultures. So this is also different from prior guidelines. We want patients, even if they, self-start therapy would be like you give the patient several days of macrobid and they could treat themselves for 5 days. But they used to not get cultures. They would just know, they would just be responsible patients, take the antibiotics with symptoms. We're not doing that anymore. We really want all patients to bring in urine for us to know what we're treating. Clinicians should omit surveillance testing in asymptomatic patients. This includes what's called a test of cure. We don't want to treat an infection with, especially when we have culture data, we know we're treating a bug that's sensitive to what we're giving the patient. We don't need to check a test of cure afterwards when they're no longer symptomatic. Clinicians should not treat asymptomatic bacteriuria. This is a tricky one, and this is all very commonly overtreated, particularly in older women who may have ASB. They don't empty as well. They have some bacteria that live in their urine. And we strongly encourage that this not be treated. It's very difficult as well because often caregivers will say, well, the patient, you know, my grandma's confused, you need to treat this bacteria in her urine. So it ends up requiring a bit of education to not do this. Clinicians should offer first-line therapy for the treatment of symptomatic UTIs, depending on the local antibiogram. And I want to show you what these are. Nitrofurantoin, trimethoprim sulfamethoxazole, and fosfomycin are considered first-line therapy, not Cipro.
Hi, Jennifer. Dr. Anker.
Yes.
Oh, your audio just sounds a little scratchy.
Oh, okay.
Audio.
Okay.
Actually,
I might have to, it might take too long to
actually,
try
no,
to get on another device.
It went away, Jen. So we'll like alert you. Yeah, it goes away. Sometimes it's just you need a break for a moment and then the mic kind of recovers is what I've noticed.
Okay.
You're doing great now. You sound perfect.
Perfect.
Okay, I'll just stay a little closer to the phone. My head's like in the screen. So just holler if it needs to be repeated. Nitrofurantoin 100 BID for 5 days. Bactrim BID for 3 days, that's double strength Bactrim. Fosfomycin is 1 single dose. Fosfomycin treats ESBL and has come back into use, but it was really used, what we say, like back in the day, even before I trained. It was used commonly, but is now harder to get covered by insurance. But with patients who have ESBL, we usually can get it covered. Clinicians should treat recurrent UTI patients with an acute episode with as short a duration as possible, generally no more than 7 days. And again, patients don't like getting just 3 days of antibiotics, but they, we try to say that longer is not better. Longer is what leads to other sequela or collateral damage. In patients with recurrent UTIs with acute cystitis episodes associated with cultures resistant to oral antibiotics, clinicians may treat with IV therapy for a short of course of possible, generally no longer than 7 days. This is hopefully uncommon, usually with most patients, but as we see older patients with recurrent UTIs, this becomes more of an issue. Following discussion of the risk, benefits, and alternatives, clinicians may prescribe antibiotic prophylaxis to decrease rate of future UTIs. So these are the prophylactic regimens we recommend. Trimethoprim is great for patients with a sulfa allergy, and then single and double strength trimethoprim sulfamethoxazole. macrodantin 50 or even 100 daily. And then here you can add cephalexin, as well as phosphomycin, which is given for prophylaxis every 10 days. In women who have postcoital UTIs, we give prophylaxis at the time of sexual activity. Guideline 12 is following discussion of the risk, benefits, and alternatives. Clinicians may prescribe antibiotic prophylaxis to decrease the rate of future UTIs in all women. This is the same guideline, but here we're talking about specifically giving them prophylaxis at the time of sexual activity. And as Dr. Nihira said, you know, women who have UTIs are the cleanest patients, and they feel like they're doing something wrong. They feel like sometimes they'll break up with their boyfriend, they'll make them get a circumcision, and all these things are really not necessary, and it requires a lot of educating to tell them that it's not about them being dirty, and often just a preventive antibiotic can help the problem. And these are the dosing of the same drugs basically for at the time of sexual activity. Clinicians may offer cranberry prophylaxis for recurrent UTIs. There are some studies that show good efficacy of cranberry. And at first we made this level of grade B evidence, but the problem was all the trials used a different formulation of cranberry, and none of the trials used cranberry that we can actually find in the store. It were these special formulations for these studies. So there's a lot of promise with cranberry, but unfortunately, we can only make this a conditional recommendation because I want to be able to tell patients what formulation to take, and we still can't really do that until we have more evidence. One study found that increased water intake helped reduce recurrences. So we do recommend that patients drink at least 1.5 liters of fluid daily, and that should help. The problem is this study had lower intake at baseline. And so more studies are needed to see about patients who already are drinking high volumes of fluid, and if additional water might help those patients. 14, clinicians should not perform test of cure. I covered this already. Again, because a test of cure is essentially attempting to identify asymptomatic bacteriuria, which we don't treat. 15, clinicians should repeat cultures to guide further management in women with persistent symptoms. We see the classic patient has a UTI, it's treated, and her symptoms persist. Often the dysuria goes away, but she's still bothered. And we see this as almost like an inflammatory response, and their symptoms persist. It could even be there's a component of painful bladder pain syndrome, or IC. So we don't just switch antibiotics. We want to get a culture before changing antibiotics in these patients, because this is the patient who could potentially have a resistant organism. Now, I'll be totally honest, in the setting of COVID, I've thrown some of my good practices out the window because we're trying to avoid patients having to come in. So I've been feeling very guilty about my recent management of UTIs by phone. Number 16, in peri-postmenopausal women, clinicians should recommend vaginal estrogen therapy to reduce the risk of future UTIs if there's no contraindication. And this is strong evidence. I have here, urogynecologists and female urologists know how to give estrogen therapy, but we have lots of options: tablets, ring, vaginal cream. For patients with poor compliance, the ring can be nice because we know they're getting the estrogen they need. But this is strongly recommended for peri and postmenopausal women with recurrent UTIs. Here is the algorithm that you can identify at auanet.org. We have the details of the guideline as well as the algorithm available online. And I want to thank you to our panelists, including Dr. Ackerman, who will be up next.
Yes. There we go. Can everybody hear me now?
Yeah.
Wonderful. Okay, so I am going to get started with some cases. There we are. Let's see how that goes. All right, we seeing this? Thanks, great, okay. Jessica, do you wanna start us off? We have for our first case.
Sure. So this is a 25-year-old female. She's having recurrent episodes of dysuria and hematuria starting 1 to 2 days after intercourse. She typically goes to the urgent care. She does get her cultures done, and her cultures are growing E. coli greater than 100,000. Typically resolves with antibiotics, and symptoms resolve between infections.
All right. So in terms of an initial workup for a patient like this, you know, in a young woman with recurrent UTIs who has postcoital infections, I think one of the things I always like to keep in mind is talk about anything that might be influencing their susceptibility to infections. Some of the things that people don't necessarily always think about are, you know, as Jen mentioned earlier, these patients tend to be very, very clean. They tend to pee before sex, pee after sex, wash before sex, wash after sex. They're doing all of those things. So you have to delve into some of the stuff that they maybe don't realize can impact their susceptibility, things like spermicide usage. That can be definitely something that predisposes. And the other thing that we don't necessarily think of as a risk factor is oral contraceptives or other hormonal types of medications that can alter sort of their vaginal milieu. So a lot of those, especially the low dose oral contraceptive pills, can really make a vagina that almost is postmenopausal and can have an altered microbiome and different protections for them. And so that, you know, may not be a modifiable thing for a patient with you know, a need for birth control, but it is something to think about, that if they're using a lot of spermicidal lube, they're on an oral contraceptive, they may be somebody really who's, you know, try to get them on a different oral contraceptive or a different type of contraceptive, maybe something more like a hormone-eluting IUD or something like that, if this is really becoming an issue. But otherwise, I think, you know, the in terms of workup, as Jen mentioned in the guidelines, you just want to make sure to do a normal exam, including a pelvic exam. Make sure there's no other obvious sources of pain or sources or any cysts or anything abnormal, and that's usually pretty much enough. All right, so for this particular patient, I did mention the susceptibility that can come, especially with low dose oral contraceptive pills. So she has that as a risk factor, but otherwise everything else is pretty normal. And again, that sign of mild vaginal atrophy that can kind of occur with contraceptives in this population. So that's something that you could talk to her about, but otherwise no other sort of alerting factors. So in terms of diagnostic testing or imaging, as we mentioned before, really these are reserved for more complicated patients. And in a patient like this, who's really a kind of our index patient, there isn't a lot of evidence that cystoscopy or any kind of imaging like a voiding cystourethrogram or a kidney ultrasound or any of that kind of stuff actually does anything to benefit the patients. And 99.5% of the time, it's going to all be negative. So really, I think what you need to focus on is getting this patient on appropriate suppressive treatment rather than starting to look for crazy zebra type explanations for why they get your UTIs. And they need to be counseled about that too, just about how common this is, and that it's very, very unlikely that anything's actually, you know, that anything's wrong about them, because they do need to be reassured a lot of the time that there's nothing physically, you know, wrong with them. They're not at fault for this. There's nothing really that they could do to change this. We just need to get them on the appropriate therapies.
Dr. Ackerman, would you switch their contraception? Is that proven to be helpful to change to a different formula of contraception?
I think it can be. There's a couple things you can do if they can't release. So hormone-eluting IUDs tend to be a little bit easier in terms of a lower risk of UTIs. But for some patients, that's really not an option, and they really need to be on an oral contraceptive, or they're on an oral contraceptive for other reasons, you know, for for endometriosis or other, or dysmenorrhea, whatever the reason is, they need to continue on that oral contraceptive. You can do a topical estrogen or estrogen testosterone cream, just a little bit of a film to the vaginal introitus, to the vestibule. And that can help a little bit with some of that restoring of the microbiome. You got to keep the dose really low, because otherwise they'll have heavier bleeding and things like that. But just a light film right at the opening, very small amount of a vaginal estrogen cream or combined estrogen testosterone cream can help a little bit with some of that susceptibility. But some of it, you may not be able to get around. You just have to get them on another type of medication that prevents infections. All right. So for the next part of her story, she sort of remembers suddenly, and this happens, I don't know if this happens to you, Jen, but this happens to me a lot. I get these patients that are like, oh yeah, I remember my mom told me that I think I had this thing when I was a kid, and they don't remember it well because a lot of, congenital urinary anatomic differences can manifest very early in life, things like reflexing ureters or ureteroceles. There are structural abnormalities of the urinary tract. They tend to manifest early, and patients don't always remember being a 4-year-old going in to get a cystoscopy. And so sometimes this is something that they really need prompting to remember. But if there is any of that kind of history, and I actually also do try to figure out if they ever had urinary tract infections when they were a kid or were getting antibiotic treatments, because that's not normal. And if that is present as a historical factor, as in this case where she remembers doing some kind of catheter test and she remembers taking antibiotics for a while, that to me sort of raises this red flag that maybe she was at least evaluated for vesicoureteral reflux. And if that's the case, it does bear a little bit, I get a little more cautious with those patients. I may not do just water as their only, preventative measure. I may try to do something a little more aggressive. For that may push you a little bit more towards the idea of getting some imaging. If there is this strong history that maybe there was an anatomic effect and a childhood history of UTIs, then it isn't unreasonable to consider doing this kind of imaging study. Jen, do you agree? Do you have anything to add?
No, I agree. There was I do agree. There was another, it's sort of right to the prior slide, a question about if there's data that switching contraceptive type decreases UTI frequency. So I thought this might be a good time for you to answer that one.
Sure. I'm not aware of any. I think that there's good evidence that there are other types of effects that can be impacted by switching birth control that are more of those things that go along with that hormone deficiency, like vestibulodynia is definitely impacted positively by switching types of birth control, and that those physical findings of the atrophy that you can see in young women who are on low dose birth control pills. I'm not sure if there's actually anything that shows that. I think, but I think it's just, we know that the low estrogen state of menopause is associated with an increased risk of UTI. And I think it's just important to remember that those aren't the only low estrogen states. You can have a very low estrogen state from taking an oral contraceptive, and you can also have a very low estrogen state in that peripartum period, especially if you're breastfeeding. And so those are important times to remember that there is that hormonal influence. Maybe even just outside of UTIs, also remember that painful intercourse can be a problem, and reduced lubrication and all of these things. And that may be part of the overall complex, in that, if you're using a lot more lube and you choose a spermicidal lube, then maybe that's all kind of part of that picture. And I think it's just an important thing to kind of keep in mind, but I'm not aware of any, I don't know if anybody else is, but I'm not aware of any good evidence that shows that birth control pills per se are linked to an increased frequency of infections.
It's hard with young women.
They're all everybody's on them.
I hate telling young women you need to stop using condoms, but really, especially in particular, non-oxynol 9 is highly associated with infections. So we often have them switch, so maybe they could go to a pill for women who are using condoms. But there's so many other risks of that. Sometimes, you know, that's where I start saying, well, just maybe take a preventive antibiotic and then you eliminate that problem.
Yeah, just try to get them.
For the main challenge that I have is just making sure I'm empowering women rather than trying to just flip all sort through an assortment of contraceptive devices and whatnot, because it can get quite complicated. So in that case, it's just making sure they understand they have a choice.
Absolutely. Absolutely. All right. So in this case, where this patient actually does have this history that could suggest something more concerning, you know, this is the algorithm that's associated with those, with the guidelines. And for most patients, we don't need to do any kind of imaging. But in situations like this, where somebody actually has a strong history of infections, even as a child, when obviously that wasn't postcoitally induced, then it's reasonable to think about doing some kind of evaluation. So for this patient, I might do a cystoscopy or renal ultrasound just to make sure there's no persistent hydronephrosis that might suggest she has, you know, persistent vesicoureteral reflux or anything else anything abnormal that might prompt me to go looking more for an anatomic abnormality or some other underlying abnormality in emptying that could be responsible. But for her, she looked fine. And so we get to talking about what we should do for her. And so she, like many of the patients that I'm sure we've all seen, comes in talking about like, well, what am I doing wrong? You know, what am I doing that I shouldn't be doing that's making this happen to me? There is a lot of blame and a lot of guilt. And when patients have these recurrent infections, and it really is highly impactful on their lives, on their relationships. You know, some people blame themselves and they fear sex, and that really impacts their relationship. Some people are angry at their partners. They blame their partners for being dirty. You know, Dr. Enger mentioned, you know, how that, you know, these patients tend to go to extreme lengths to try to avoid these things. And I think at this point, you really have to have a discussion with the patient about how it's more about the nature of the disease and it's more about the bacteria and their adhesion properties. I mean, you don't have to get into that, but the point just being that they need treatment, they don't need guilt, they don't need blame, and we need to get them. I think suppression therapy or preventative therapy is useful, not just for keeping them from getting infections, but it's also good for managing some of these psychosocial impacts. It gives them a way of saying, I'm protected and I don't have to be afraid, and a way of trying to get past some of that. Almost, it's, you know, PTSD is probably a little strong for this, but there is that element of just like, they're so afraid and there's such this negative aspect to, especially to intercourse when that's involved with the pathophysiology of their condition. And so that's definitely the biggest thing. So to really get them into a treatment plan rather than blaming the patient or telling them to modify their risk factors. As there are studies actually that do look at, is wiping front to back or peeing after sex and all of these things useful, and they're really not. So that doesn't stop many of, you know, you're probably not stopping your patients from wiping front to back and peeing after sex. They're going to keep doing that, and that's fine, but that's not treatment, and that's not a treatment plan. And so we have to kind of get out of that idea that the patient can somehow modify all of this on their own to fix everything. We have to give them the sense of it actually being an intervention and a plan, even if their plan is increased water intake, but there's science behind that. So that's okay. You know, sorry, Jen, you were going to say something?
That's what I was going to say. The only behavior modification that's been shown to be effective is increased water intake to over 1.5 liters a day. But other than that, I agree with everything. Exactly.
Yeah. So let's see. Oh yeah. So this particular patient, you know, she's been on a million courses of antibiotics. She really doesn't want to do it anymore. And she's asking if there are other options and for treatment. And, you know, as we went through, cranberry has a lot of potential We don't know how to give it, I think, is the problem. But for patients like her, where she's never had episodes of pyelonephritis, she's not at great, we don't think she's at any great risk for ending up in the hospital with an infection. She's responsible. She gets cultures every time. Doing something like a supplement, like a cranberry supplement, and increasing her water intake seems like a very reasonable first step, especially when she's very adverse to using an antibiotic. And so she opts for increasing her hydration and just taking a cranberry every day, or twice a day. You know, again, the regimen is really hard. We don't know what the right one is. I tend towards using some of the, you know, you can find cranberry supplements in the supplement section, and you can find cranberry supplements in the women's health section. And there is no reason that I know of that I use the ones in the women's health section, which are things like, to mention brand names, things like Allura or Azo has a cranberry brand, Cystex has a cranberry brand. I tend to use Allura because I know that that brand has a fixed amount of what's called PAC, which is what we think is the active ingredient in cranberry. I have no evidence for that, but that's what I do, just because I feel like at least it gives me a consistent understanding of what the patient's going to end up getting. So if they want to try that, that's what we try. You take it twice a day, increase their water intake, and let's see how she does. She asks if she should take other stuff. So there are other, sorry.
What about the other kind of commonly discussed, like lactobacillus, D-mannose, or methanamine? What's the conversation with that? Are you never using it, or are there certain patients that you feel like the evidence does support?
So as far as D-mannose goes, you know, there's the hypothetical evidence that it should be effective against UTIs. And I say hypothetical, meaning like the concept makes sense, like it should block adhesion of bacteria to the bladder and prevent infection. It's never really been shown in an appropriately done study that it actually has a positive effect on preventing UTIs, but there's also no harm that has been demonstrated either. So I feel like if patients are just like, I want to throw the book at this, like, fine, they can take it. They can get expensive, so I don't push it. But if they say, I want to try everything under the sun, can I take D-mannose? I'm totally fine with that. Some of the other stuff that you'll find that are more in the supplement range for UTIs are a little bit more unclear, and there could be potential harm. So I tend to discourage everything else. Like vitamin C is probably fine. That has a tendency to acidify the urine. That may have help. But there are things like uva ursi, which you can read a lot about online, that may have some impact, but there's also some very unclear health risks. It's probably fine, but I don't feel comfortable making a positive recommendation for something that might have harm and doesn't really have any viable evidence. Methenamine is kind of a separate case. I mean, that's a prescription medication. And methenamine, so for anybody who doesn't know, methenamine hippurate is marketed under the brand name of Hiprex. It's typically taken at very high doses, 1 gram twice a day. It's a horse pill. And, but what it does is it actually is secreted into the urine and converted into formaldehyde within the urinary tract. That's a positive, actually, because it acts as sort of like, I call it like Lysol for the bladder. It's not an antibiotic, so it doesn't kill an active infection. But what it does do is it's bacteria static. It prevents bacterial growth. And it does that with minimal consequence to the gut or to the vagina. So patients who have really high incidence of yeast infections every time they take an antibiotic, this is something I use a lot. And so it doesn't have those side effects. And its big side effect is that it can give you like some stomach discomfort. That's the biggest thing. And in some bad studies, looks really great. So there aren't really great prospective randomized trials, but there are retrospective trials that seem to show equivalence with a typical prophylactic dose of something like macrodantin or nitrofurantoin. And so I use it a lot. I feel like it empowers patients to know that they're doing something without that antibiotic side effect. So that's definitely something I think is very reasonable. They just can't do it on their own. They need a prescription.
In the urology world, we've used this for a really long time. And I was like shocked that when we did the systematic review that there wasn't enough evidence to support it. So there is a trial that compares methenamine to prophylactic antibiotics that is underway. And so hopefully we'll have more data to support it. But I think, as speaking for most of us who use it, we're pretty convinced that it works close to equivalently to preventive antibiotics. So when patients start developing resistant organisms or just get really kind of panicked about recurrent UTIs but don't want to take an antibiotic, I think it's a really good option.
Great. So she does well on this regimen of water and cranberry, but then eventually comes back with another infection. She comes back with the classic symptoms of acute onset dysuria, hematuria, nothing more suggestive of a pyelonephritis, but she's, concerned that we haven't done enough. 2 months is not a very long time to go without an infection. So at this point, this may be the time to consider a change in treatment. And so the important thing to know is, despite the fact that she's had cultures all this time, they've always been positive for E. coli, it is important to at least try to get another culture when she's symptomatic to make sure there hasn't been a progression of her symptoms or a development of antibiotic resistance. And so it is always crucial to get that culture. So with this one, her initial UA comes back really highly suggestive for an infection. And eventually, a couple of days later, the culture comes back with the same pan-sensitive E. coli that she's had all of this time. And so she asks for treatment. What are we going to give her? Well, we went through this a little bit in terms of our first line drugs. We want to try to, again, stay away from the stuff with higher systemic effects, or that collateral damage like ciprofloxacin and the fluoroquinolones, and focus on these three that are the nitrofurantoin, trimethoprim sulfamethoxazole, which is Bactrim, and fosfomycin, as good first-line agents that have the best sort of tissue penetrance and urinary penetrance to less collateral damage. That's kind of the nice balance that we're trying to get. And then she tells you that she's always gotten Cipro for 10 days in the past. And so, I think that's a very common story we hear from patients, that because I'm sure everybody else has heard this, the patient comes in and they say, well, I've had recurrent urinary tract infections. And then, you'll get a call from their primary care doc that says, well, because she keeps having infections, should I give her 14 days of Cipro this time? And there is a very simple answer to that, and it is no. The shortest and most focused antibiotic treatment for the case is the best. And 3 days of Bactrim, 1 dose of fosfomycin, and 5 days of nitrofurantoin are all thought to be sufficient for the treatment of acute cystitis, whether they've had 15 episodes of cystitis before or none. And so extending the course or changing the antibiotic when the bacteria is susceptible to one of these three agents, neither of those things are recommended. In fact, they are recommended against. Don't do those things. Again, the focus should be on treat the acute episode the way you should treat any acute episode. And in patients who have recurrent episodes, we have to focus on ways of preventing the recurrence, not treating the acute episode differently, if that makes sense. So let's talk about, so she gets treatment for this. And this is kind of the same concepts. This guideline statement covers that idea. So treat acute cystitis episodes with the duration of antibiotics that is reasonable and as short as possible to treat their infection. So she gets better, as she always does with these treatments, but now she's like, maybe cranberry is not enough. What should we do instead? And we come back to the idea that antibiotics and other things can be used as prophylactics to prevent the UTIs from happening in the first place. So for postcoital, she's sort of that situation where her episodes tend to pretty much always be related to intercourse. And so when you have a known sort of trigger, something that you know always happens immediately beforehand, you don't necessarily have to give continuous prophylaxis where they take it every day. They can only take it around the time of that trigger. Intercourse is obviously the most common trigger. And for postcoital prophylaxis, they just need to take it within a couple hours of intercourse. I sort of give them if they go to sleep right afterwards and they wake up the next morning and they take it then, that's probably okay. If they can take it right afterwards, that's also probably better and will help them sleep better, most likely. This is a single dose only. You don't need to give a course. And so for postcoital prophylaxis, you can give what's basically a single strength Bactrim. So that's trimethoprim sulfamethoxazole, 40 milligrams, 200 milligrams, or a double strength. And then nitrofurantoin, I tend to give macrodantin, that formulation better, either 50 or 100 milligrams. And you can also use something like cephalexin. Fosfomycin is difficult to use in this context because it comes in a 1 dose, 3 gram. It's hard to get, it's expensive. So that's more of a practical thing. We don't use it for that purpose. There are other types of prophylaxis, but for her, we choose the intermittent dosing. I do have a discussion with my patients who are sexually active about, I hate to say this, but the frequency of sexual intercourse, because if they're having sex pretty much every night, they might as well be on continuous dosing. And if they're really having sex, in intense, like I have a lot of patients who tell me their boyfriend's not living with them. He comes back for only, 1 week of the month or something like that. Then they only need to take it that 1 week. They don't need to take it the other time. So really try to tailor it for whatever their triggers are, if there are clear triggers. In our postmenopausal women, that may not be the case. You may not have that clear trigger and they may need to be on continuous. But I think it's just what you're trying to do is overall reduce the total dose of what they're getting and really give them the opportunity to make sure they're preventing those infections with as little medication as possible. Oh, that's interesting. Funny animations. So anyway, she gets nitrofurantoin and she takes this religiously. She does great. And she comes back a year later and tells you she's getting married with this boyfriend that she's had who, they were having trouble there for a while, but now they're great. And she's traveled, but for her honeymoon, she's leaving the country and she's worried what will happen. She doesn't want to be unprotected in that time. And so she asks you, what should we do? And I think this gets to that question of, how we're taking care of patients now versus how maybe it used to be pretty common to just give patients what we call self-start treatment, give them, or what I call a just in case antibiotic prescription. And that's very reasonable to do for a select group of patients. And I think it has to be patients like this, where you trust that they're not going to use it anytime they feel the little twinge of something. And if they can get you a culture, they will. And it's not going to be the kind of thing that they're taking all the time. And I think, especially when people are traveling out of the country, or they're going to be in a situation where they don't have access to care, and you've been through this workup, they have infections, it is a very reasonable thing to provide them with an antibiotic course, and just know they may take that without you knowing what happened during that episode. I think that's totally fair and nice. All right. Sorry,
For patients that may have let's say they have reduced kidney function, would you change your dosing or duration for this intermittent antibiotic use with either postcoital or self-start?
Yeah, I mean, absolutely. So you'd make those same dose adjustments. So in general, the way that I sort of think about prophylactic dosing is it's basically like a quarter of the dose that you'd regularly give. So 50 milligrams of nitrofurantoin is a quarter of the 200 a day that you typically give. And that 125 or 250 of cephalexin is about that same amount of a Keflex full dose. And so if somebody has renal function where their full dose would be whatever that is, just again, same kind of thing, a third to a quarter of that, whatever's able to be given in a pill form, that should be kind of their prophylactic dose. So that's just the general rule of thumb. And again, the thing to remember is if they do have, consistently infections that are always resistant to drug X and Y, and you need to give Z, use that same kind of theory. So maybe you have to use, something a little different. And if you did have to use something like Cipro, again, you want to give that quarter dose of whatever their full dose would be.
Great, thank you. I think we have 10 more minutes left, so why don't we try to get through some of case 2 and see, and I'll keep bringing up questions from the group.
If it's okay, I think what I'll do is so case 2 is a little bit more about like, I'll give it away here about distractors. So this is a woman who basically comes in, who really doesn't have positive cultures. They're always contaminated. She's really got chronic frequency and discomfort and vaginal pain with intercourse. And so it's a little bit more about talking about some of those whoopsie, now I've done it. Talking more about those distractors, which hopefully that was enough to sort of give you the like blinking light of make sure that these are really UTIs and that you're not looking at something different. I think the big thing for them is just to keep in mind that if somebody's having symptoms between infections or chronic symptoms, you have to sort of start your brain thinking about what other stuff could be going on. And remember that dysuria, while it is that really, really highly specific sign for urinary tract infections, can also be a very, very common sign of vaginal atrophy in older women and vaginitis in all populations. And so those are just things to keep in mind. Probably more useful to go through this third case if everybody's good with that.
Dr. Ackerman, that's one of the fellows had asked, when would you use these kind of non-traditional expanded urine cultures? Is that a group that the constant dysuria, is that a group that you would use that for?
I don't, but I feel like that's a great question. The reason I don't is not because I don't believe in it. It's just that I don't know how to interpret it. I have seen patients who've come in, I have this large, unfortunately increasing group of patients who have been, so let's take a step back. So the expanded urinary cultures, there's a couple different varieties. There's both expanded clinical culture techniques where you actually are taking the urine and you're just culturing it in more ways and in larger amounts so that you get a more sensitive culture methodology. And then there are sort of the molecular diagnostic techniques, and these are PCR/sequencing, often in combination based techniques that are detecting bacterial DNA and don't require culture. They are very sensitive and can give you a much more complex sort of readout of what the urinary bacterial population looks like. Two things, which one is that both of those methodologies will be positive in perfectly asymptomatic patients and normal women. And so the question about what they mean is still really unclear. And then secondarily, there's never been evidence, and there are trials going on right now. So I am waiting for those trials to come back with an answer to this before I implement them in my practice is kind of the short answer. But there are trials right now to figure out if guiding urinary culture treatment or guiding these symptomatic treatment of patients with these more chronic symptoms, using these methodologies actually makes a difference in care. Because, there's 20 different papers out there that show we can more accurately find bacteria using these studies, but none of them say you can actually impact the quality of or the outcomes for these patients using these more sensitive methodologies. And what I have seen anecdotally is a growing number of young women, particularly with these chronic symptoms, who have been given these molecular diagnostics techniques in particular and treated with escalating doses of more intense antibiotics. I had a 27-year-old in my office a couple of weeks ago before this coronavirus thing happened, who had gotten 3 courses of intravenous meropenem for chronic dysuria. And that to me is harm to a patient. And so I hopefully, I'm not against using them, but interpreting them is the challenge. And I personally just don't know how to do that yet. So I don't order them. And I think interpreting them that way is very bad.
It definitely leads to over treatment because they're going to be positive. And I feel like when I've seen it in practice, it tends to be sort of a money making where there's a connection between the doctor and the lab. So I don't tend to, it's not what's happening in practice doesn't seem trustworthy.
To me, I agree that it's a kind of like saliva testing and hormone therapy for estrogens.
I didn't even know about that.
Yeah, I know. I wish I understood what that meant. It says the urologist. Great. So Jessica, do you want to take us through case 3, maybe?
Case 3, 84-year-old independent living female with recurrent UTIs, also complaining of some pain with initial penetration with intercourse and vaginal dryness at baseline. Infections come with worsening dysuria, frequency, urgency, and she does have some baseline dysuria between episodes, but no episodes of pyelonephritis. So this is a common patients that we see.
So again, just kind of in that initial evaluation, we want to do a good exam for her. This question of dysuria that she's having between cases prompts me, especially in this age group, to think about vaginal, so genitourinary syndrome of menopause, what we used to call vaginal atrophy, which I still call that most of the time because I forget. And anyway, on her exam, she has pain throughout the vestibule and these erythematous patches and the resorption of her labia minora. And so she's obviously clearly got that hypoestrogenic state of menopause that's leading to at least some of that baseline dysuria, and may also be contributing to her infections if on our clinical review, that's really what we find. All right. So she comes in today and she is not feeling like she has an infection today. And what I see a lot is that patients are just tested randomly in this situation. And that's not what we recommend. I think that, there are reasons why you could decide to get a urinalysis in a patient like this, just to look for proteinuria or to look for blood in the urine if you're screening for those things for other purposes. But to do a surveillance urine culture in this patient who's not having active signs of an infection isn't really helpful. And so this is, I think, one of the biggest debates, and maybe this is a good time to get into it, Kira, if you want to, is what does it mean to be asymptomatic in a population of women, like particularly in older women, where they have baseline urinary symptoms, but they don't really have suspicion for an infection. And so I think this is where it's just really hard to get people to understand, because it's really a feel. Does that make sense? Like there's in this patient, if she's at that point where she has that kind of little bit of baseline dysuria, I would call that baseline and I would not call it symptomatic. So I would not test her, because if it came back positive on a culture, that would be asymptomatic bacteriuria, which we don't treat. In a patient with, say, bad overactive bladder, where they have a lot of frequency and urgency all the time, so if you test that patient, to me, and it comes back positive, it's still asymptomatic bacteria because they're not having symptoms of an infection. And we really have to be stricter about defining what that means in terms of acute onset dysuria or hematuria associated with worsening urinary frequency and urgency, and or signs of a systemic infection that may make you, but that systemic infection signs have to come with urinary symptoms. So you have to have some kind of urinary symptom, and then they have a fever. That's fine. Test that. That's good. Test that. Absolutely. But in the patient with, change in mental status, a patient who is wheelchair bound and mildly demented at baseline, and I have a change in mental status and no increase in urinary frequency, no hematuria, that is not a UTI. And that is a culture change that I'm sure we're never going to be able to make, but that is something we all have to, if we can all toe the line, it will make sure that those patients get treatment for whatever is actually causing their change in mental status, which is unlikely to be their urine.
I just want to throw in there, the other thing that's problematic is these patients often get brought in because their urine smells, and that's not considered a symptom of a UTI, although it is often asymptomatic bacteriuria can cause smell. So sometimes it's more, that makes it even more tricky in this population. It's just a very difficult population, I think, to try to differentiate infection versus colonization.
And just to get back to points, unfortunately, we're at the end of our hour here. It went by quickly. So I just want to take this opportunity to thank everybody, thank our wonderful panelists for their discussion today. I think we covered some really great information. Also just like to remind everybody that we're doing these webinars every Tuesday and Friday. The next webinar is May 12th at 5 p.m. and that will be Painful Bladder Syndrome by Dr. Howard Goldman. We look forward to seeing you then. If you can't watch it live, you're back to work and need to be busy, we have the recorded versions on the Society website, or you can find it on YouTube by searching AUGS Fellow Lectures. Thank you, everybody. Stay well.